per year over the next 10 years. So they actually talk about in the wider document about why they didn't consider any other radical options. And the reason why I guess I particularly wanted to discuss it was that this does come up a lot. And I think we'll maybe talk more about this issue about, well, why is it? And I know that Louise has a view, and that's partly the reason why I brought this in here, is that actually maybe that's not the big issue. Maybe the big issue is, why do we have one list for certain conditions and other conditions? And it's never changed pretty much since it was first enacted. Anybody got a view on this? Louise, do you want to kick us off?
Obviously, I can only think about HRT, but every other hormone or treatment is on it, isn't there? So if I had an underactive thyroid gland, or if I had diabetes, I would have free prescriptions. And we know there's a study that came out last year showing that women from low socioeconomic classes are about 29% less likely to receive HRT. We know these women are more likely to have cardiovascular disease, more likely to have mental health issues, more likely to be obese, so actually more deserving of HRT. One of the things that I'm also doing is working as an NHS advisor for the National Menopause Programme, and I've been pestering them for a long time, and they're finally listening because I'm selling it to them as a health economy problem, because we know that if women don't get the right treatment, they're more at risk of these conditions. If you think about an osteoporotic hip fracture, it costs the NHS £3 billion a year. We also know that we did a study of 5,000 women, and we found that 10% of them, it took 9 GP appointments just to get the diagnosis of menopause. If women can make the diagnosis themselves, for example using the Free Balance app, then we could free up 750,000 GP appointments a year. So that's quite a lot of money actually that is just saved. So giving something that costs £4 a month, even though potentially that's for the majority of women, you just got to wait. You've got to be a bit patient, but 10-20 years time you've made your money very easily. And I think this whole postcode lottery, we've been doing some mapping of who gets HRT, and it's completely wrong. And then we did some deprivation scores of who comes to my clinic, and you've only got to look at my website. The fees are eye-wateringly expensive to come to the clinic, and 10% of our patients are from the lowest deprivation index. It's shocking. You know, we see people that they come and they've been given £10 from every family member to come because they just want their lives back. So this shows how desperate women are. So I think it's really wrong that they have to pay.
I'm in agreement with that. I mean, first of all, the specific thing about the lists, it's a nonsense that there's two lists. It's an absolute nonsense. Why is one chronic condition trumping another one in terms of what you get for free? But I suppose I'm in the mindset, and you know, I live in Wales where we've had no prescription charges for, I think it's over 10, 15 years. They're a false economy. They contribute to health inequality. They don't save money in the long run. 600 million sounds a lot. It's not in the grand scheme of things. And Louise then just said about the knock-on effects of women not taking their HRT end up costing you a lot more money. Well, that was the subject of a report in 2017, and organisations like the National Rheumatoid Arthritis Society and Parkinson's UK produced a paper that showed clear evidence of this, that people were not taking their medicines. Now, you can imagine the consequences of not taking your Parkinson's drug because you can't afford it. You are going to cost the NHS a lot more money. So it's a complete false economy. I think it's a historical stroke political thing that is an anachronism in a modern health service, and the clear answer is scrap it. And if you're worried about increasing prescription numbers, then sort out your repeat prescribing system.
Yeah, I mean, I find it hard to get excited about this because, again, it hasn't been an issue for us in Wales for so long. You know, when it happened, I remember taking a call. It was 2007 or 8, and we reduced prescription charges, hadn't we, over the previous years, and then they were abolished in 2007 or 8. And I took a call, and they said, "Oh, wait, can you supply us with the evidence? We need to follow you." And I said, it'd be nice, but we don't have the evidence. And it was a political decision at the time, I think. But since 2010, and where we published a few papers, and David Cohen was our one of our health economists who published the papers to say, actually, nothing to see here. You know, the big reaction to getting rid of the prescription charges is going to, it's going to drive prescribing and in other directions. It never happened. And so all of a sudden, those health inequalities that Gimmo's describing, it's just so nice to have those conversations without cost of prescriptions coming into the equation for us.
It's really interesting that you say that there was no evidence. at the beginning when Wales decided to do it, because I did say at the beginning that I have a slightly controversial view about this. So I'm going to give it to you and then hear what you will have to think about this. This isn't based on evidence. This is based on my 30 years of working in the NHS, but I'll give it to you anyway. And so this has been going on, and there isn't any doubt that the system as it currently stands is bonkers. And what we need is a system that's simple, fair, and easy to administer. And I also think that to seek to engage patients as partners in taking their medicines to improve adherence, reduce adverse effects, and reduce waste. And we also need to encourage people to use their community pharmacists for self-limiting conditions, and that will provide overall value, better money for the taxpayer, and a reduced burden on GP services. I also think, and this is the controversial bit, for which I have no evidence other than my own personal view and experience, is that people don't value anything that is free. So all patients, I think, in my world, could pay a nominal fee. And by that, I mean nominal. I mean 50p or £1 or whatever it might be. So that, and then there would be a limit to what that would be. So in other words, even if you were on 20 medicines, the limit would still be £5, let's say. Okay, I'm talking nominal amounts. Because I'm sure Louise would agree with me from a GP background, there are so many things that get done where people are only requested them and want them because they don't have to pay for them. And they create a lot of burden in the system. Now, I also think that there are big issues in here like cancer, for example, and this is political about why they wouldn't make any changes about cancer patients, for example. But I just have this feeling that, there are certain exceptions that are too emotive. So patients with cancer, for example, people who have got conditions that if not treated, it puts the public at risk. So that would be sexually transmitted diseases, HIV, TB, notifiable diseases, schizophrenia. And other than that, my view is that everybody should pay a nominal amount, and that would actually, people would value more what they were doing.
I can see where you're coming from, but actually, I think, again, it comes down to education of our patients, actually, because I think if they're educated and empowered, they're less likely to come asking for help for things that, like you say, you could get elsewhere. There's been so much sort of misinformation, not just about menopause, but everything. And then now it's so hard, isn't it? It's such a strain on primary care and secondary care with COVID. But I think if patients know what they can and can't get, I don't think they'll take the mickey, actually. I feel it really uncomfortable charging people because my daughter has intractable migraines and it's been horrendous. She's under 4 different neurologists, and as a mother and who has migraines herself, I feel doubly guilty because I've given her the migraines through my genes. But, it's really hard, and I think, God, if £5 for every medicine that I've given her, it's a lot of money for her as a student. Yes, okay, you could argue she'll be free, but when she's earning money as a musician, she's not going to be paid much, and she would end up not taking some of her medication. And I just look at people, £5 isn't much for some people, but actually it's a lot if you're feeding your children and you've got other things going on.
I was talking about a nominal fee. I'm talking like 50p, but if you were taking lots of medicines, there'd be a cap on what the maximum would be. We pay for dental treatment. I know we'll get into this whole NHS politics, and we probably haven't got time. But that's my view, and I just wanted to put it out there. Go on, Paul.
I think you're right about we need to get better at working with patients to help them understand not just the financial value, but understand their medicines and what it means to have them and to take them. And we've talked about that a lot. We've also talked about behavioural sort of science and economics. And so I struggled out of Lidl this evening with a load of shopping in my hand because I didn't want to pay the 20p for a carrier bag, and that's what you're doing there. You're introducing a friction cost, so the impact of what you're suggesting will be that the charge doesn't matter, but the art or act of paying will mean that people will err on the side of not taking over taking. So I think it'll have the same impact as prescription charges, whatever the value is. And I think I agree with Louise as well, is that any sort of cost, even if it's nominal, will impact the disadvantaged hardest. It'll have less of an effect, I agree, than £6, but it's still going to have an effect on health inequalities. So I get what you're saying about value it. I've heard this argument loads of times, and I think it's worth thinking about. But
remember, it's nearly 10 quid an item now, guys. Not 5 and 6 quid. It's nearly 10 quid an item.
I know. It shows last time I did it.
I also think we've all been on house visits where we've looked at this polypharmacy, especially it's worse, isn't it, as people get older, and these people often don't pay any prescriptions. And you say to them, oh, what do you want? And you open the cupboard and it's fallen on top of you, isn't it? All the bisphosphonates that they don't want to take because they get side effects, all the analgesics, everything, and a lot of it is because they're too scared to tell the doctor because they don't want to upset them, because but that doctor was so nice when she gave it to me and she said it would really help me.
But that's where the nominal charge would help, wouldn't it?
Well, they're not paying for it, so they'll just
that's what I'm saying. So if you have a nominal charge, in the same argument that Gimmo's just given, that's my point. If you're not using it, right, you're not going to take it. You're not going to ask for it.
I don't think it would make any difference, though. I think.
Can I cut in here with my mediation training, please? Can we have one person speaking at a time, please? Anyway, Louise, I was going to come back to you on your episode with Dr. Sarah Hillman, and we nearly got through an episode without mentioning the inverse care law. But what was the figure from the research that Sarah did? Was it 29% lower prescribing? And
actually these people were more likely to get oral HRT, so oral estrogen, which has risk of clot with it. And actually, when you talk to some doctors, they're like, do you know what, I'm too busy, I can't do menopause as well. But then you actually say to people, well, just ask every woman you see when their last periods were, or whether their periods changed, and you can get menopause into every single consultation, or perimenopause to every single consultation, to all women actually, because, young women, my youngest patient's 14, she only had one natural period, so you don't need to stop it at a certain age either.
Jamie, we're going to enter the prescription debate, or should we draw to a close?
Oh, do you know what? I was thinking, listening to Louise's last podcast, you immediately invited your guest back on.
He's coming back.
So that's something that we should do. We should invite Louise back on for a future series to continue the conversation.
I'll be delighted.
A big thank you to Louise for joining us on the Aural Apothecary and for sharing her stories, her desert island drug, her career anthem, and her book. Coming up next time, we'll be joined by Dr. Chris Martin. Chris is a pharmacist by profession and is currently the chairman of the Life Sciences Hub Wales and co-vice chair of the Bevan Commission in Wales. His interests include innovation and end-of-life care. We will look forward to catching up with Chris next time on the Aural Apothecary. You can contact us via Twitter, that's at Aural Apothecary, LinkedIn and email auralapothecarypod@gmail.com. Over to Gimmo now for the final ingredient.
Okay, so thank you Louise, that was a fantastic, I really enjoyed that. This final ingredient, I want to talk about a colleague who's a consultant physician in Cwmtaf Morgannwg Health Board, Dr. Helen Lane. She was on the front line during COVID, obviously, like a lot of people were. Had a tough time, really tough time, and so to help her cope, she turned to writing poetry, and so she just published a book of poems, and the collection is called Reflections Through the Waves, Poems of the Pandemic. And I just wanted to mention it because I know she's very passionate about it. She shared it with people, and actually the proceeds from the book, you can get it on Amazon, go to Young Minds Beat and Wish Upon a Star. And we've never done it before, and it breaks our sort of not talking about COVID rule, but are we happy for me to read out a poem from it? So, it's good to talk. I pray he survived. I rush to the ward. He tries to smile, my greatest reward. His family so grateful, so precious but faceless. Such emotion and fear, his survival is priceless. I return to the office, I'll get through today. Then flowers from the caring, perhaps I can stay. But all staff around me still struggle each day. They suffer in silence, and dare they to say. Such supportive staff, vital cogs in the team, the grief they have witnessed, the things they have seen. Who asks the porters who hope for the best? Who cradle the sick, then carry them to rest? Who ask the domestics who clean every space? After those who kept leaving, having lost life's race? Who cares for the caterers who keep us all going, exposed to a risk, but carry on knowing that we all need each other now more than ever, and we may just survive this, but only together.
This was a 3 Apothecaries production. Sound engineer Jimbo Slough, original music Jamie Brewster, artwork by David Baker.
Thanks for listening to the Aural Apothecary podcast, where we always dispense with accuracy.
This episode of the Aural Apothecary is sponsored by jamiehayes.co.uk.